Konnichiwa. Welcome to another lecture in Counseling 5480 Diagnosis and Treatment Planning course. In this lecture, we will talk about depressive disorders. Specifically, in this lecture, we're going to talk about the following 4 disorders. They are major depressive disorder, or MDD, persistent depressive disorder, PDD, disruptive mood dysregulation disorder, DMDD, and the last one, premenstrual dysphoric disorder, PMDD. All right, let's get started. In the beginning, let's play a game to see if you're able to tell the difference between the fact and the myth surrounding the topic of depressive disorders. Let's start with this one. In the US, about 7% of the adults are diagnosed with major depressive disorder. What do you think? This one is a fact. The number of US adults who are diagnosed with major depressive disorder is very close to 7%. Did you get it right? Next one, depression only happens if something had happened to you. For example, you only get it after a bad divorce or losing your job. What do you think? Well, this one is not a fact, it's a myth. It is right, or it is true, that depression may happen after something bad happens, like bad divorce or losing job, right? But other things can also trigger it, such as some medicines, hormone, childbirth, using alcohol and other substance. They can all trigger depression, and sometimes, it just happens without any clear reason. That's why it's a myth. Did you get it? Okay. Only people who are very depressed or thinking about suicide need medicine. What do you think? Fact or myth? This one is a myth. How do you decide if someone is very depressed or not? And you also don't want to intervene too late when a person is thinking about suicide. Like, what do you mean by thinking about suicide? Do you mean I just had this thought of I don't want to live anymore, I want to disappear, or it means that I have a plan, I have a very clear plan of how do I take my life, right? You don't want to risk those things. And sometimes, you just want to function well. You just want to be able to um, function normally. And in that case, medicine can help you function. At the meantime, you can learn some coping skills or to get some counseling from mental health agencies. All right, the next one. Most people with depression do not seek treatment. Fact or myth? As you imagine, this one is a fact. Among those who are suffering from depression, approximately only about 1/4 of those people actually seek help. Is that also your experience? Do you know someone who's around you who may have some depressive symptoms, but they are not seeking help? And if you do know those people, what do you think, what factors contributed to their behaviors? The next one, children can get depression too. Fact or myth? This one is a fact. For example, one of the disorders in this chapter, the disruptive mood dysregulation disorder, is basically a diagnosis for people who had those symptoms before the age of 10. So yeah, children can get depressed, but the symptoms may look drastically different from adults. Like for adults, maybe adults are usually they're very sad, right? They cry. Children could be really disruptive. They can manifest their symptoms as some behavioral problems, but you really need to differentiate between the pure behavior issues and the mood disorders. So that's all the factor myths I have. How many did you get right? Did you get all of them right? And then, as you know, as you've heard about it, or maybe intuitively you know about this, depression is more prevalent among women than men. What do you think would be the reason? I want you to think about it, and you can write down your answers, and we will discuss this question when we meet in class next week. In general, depressive disorders have the following symptoms that can be categorized into two groups. So the physical symptoms include appetite. The person may not want to eat at all, or they just keep eating with no control. Sleep problems is very common. People usually either they can't sleep, or like they have trouble falling asleep, or they just kept waking up in the middle of the night, or they wake up too early and they just can't fall asleep again. Or all they want to do is to sleep. They don't want to get up. They feel so sluggish throughout the day. Psychomotor activities refers to um, how the brain's mental process affect on our physical movements, such as people may not they may tell you that they're not able to sit still. They constantly pacing, they constantly just rubbing their hands, rubbing their skin, or they're just fidgeting. And some of these you can obviously observe from the session that you have with them. People who are depressed usually would tell you that they feel tired all the time. They just don't have energy to do anything. So there is the noticeable lose or decrease in energy. And then again, with children, sometimes they don't know how to talk about, or like they have limited ability to express themselves. Um, So they can display symptoms like they just don't want to go to school for days, or they are appear to be more clingy to a parent. For older kids, they may get into more troubles at school as parents may get more phone calls from their teachers saying that, their children are not behaving. And because it's a mental disorder, there are apparently more psychological symptoms. So on this list, you will notice that some of the items on the list have a star at the end, and those are basically primary symptoms. The others that are without the stars, they are secondary symptoms. So these symptoms include depressed mood, like people just feel low all the time, loss of interest, they don't want to do anything, especially, they like if someone who just love to read or who love to draw, all of a sudden they just don't think those things are interesting anymore. Many of them would report you to not being able to focus, or they feel like their brain is slow, they can't process things as quickly. They always feel that they're worthless. So there's a direct link to their low self-esteem, or not like a negative self-image. Cognitively, they are thinking negatively towards the past, during the present, and in the future. They feel guilty usually about what happened or what have they done in the past, and currently they don't feel good at all about themselves, and they have no hope for the future. Thoughts of death and suicide is a key feature for people who have depression, but their words may be very vague. They may not tell you that I want to kill myself. They may just simply indicate that I want to run away. I want to disappear. I want everything to be done. I'm done. Or when you hear about these things, you may want to ask some more questions to directly, confirm. Do you want to kill yourself? Is that what you mean? And for younger children, they may come up with excuses to go to school, or they may have some somatic complaints. They would say that they have stomachache, headache, right? Nauseous, they just pretend they have fever. And there's also worry about people who are close to them are going to go away, or like the parents may die or may leave them. And for older kids, they may be easily offended. They may always just think negatively. They talk in a negative way. They are irritable. They're just not happy. They're just always not happy. At the bottom, there's a YouTube link. I highly recommend you to pause this lecture right now and then go to that YouTube link and watch another video. I think that's a very powerful video for someone to kind of who suffer from depression to try to tell people how hard that they're feeling when they are misunderstood. Every time I watch it, I feel, even more powerful. So highly recommend. First, let's talk about MDD. By now, you probably have already noticed that when it comes to diagnosis, you want to pay attention to the required number of symptoms that the person need to have in order to meet the criterion. So like here, criterion A, there are 9 different symptoms listed under criterion A, and 5 is the minimum number of symptoms that the person should have in order to be considered as major depressive disorder. And then the second thing that's also very important is the duration of the symptoms. So again, in this case, according to criterion A, the duration for those symptoms needs to be 2 weeks. Something special for MDD is that at least one of the 5 or more symptoms must be either depressed mood and or loss of pleasure. Okay, so what do we have under criterion A? We pretty much went over all of these symptoms already in our previous slide, so I wouldn't spend extra time to explain. But basically, the symptoms under this criterion, including someone's mood, feeling low, loss of interests, weight gain or weight loss significantly, insomnia or hypersomnia, psychomotor activity, feeling restless, can't sit still, or feeling sluggish, just don't want to move at all, fatigue, exhaustion, feelings about self-worth, self-esteem, self-image, trouble with concentration, and the key feature, suicide, suicidal ideation, suicidal behaviors. Criterion B is trying to quantify the severity of the symptom. So the symptoms needs to be severe enough to cause clinically significant distress. How do we determine if they're significant? We use our own clinical judgment. And usually, a rule of thumb is that the client's symptoms have not only impacted on just one area of their lives. Usually, the symptoms are impacting different areas such as their personal life, their occupation, their school life, the relationship with family, and in various settings. Criterion C requires you to make sure that the symptoms are not caused by another substance or another medical condition. Criterion D is the differential diagnosis criterion, making sure that this disorder is significantly different from other mental health disorder or other diagnosis. Here it gives you 2 examples, including schizoaffective or schizophrenia. And you can find more differential diagnosis on page 167 to screen from. And then lastly, there should not be any presence of mania or hypomania. In a different lecture, or the second part of this lecture, we will go through bipolar disorders. If there's any presence of mania or hypomania, even if people also have depressive symptoms, we usually would consider the diagnosis of bipolar 1, bipolar 2, rather than major depressive disorder. Speaking of bipolar disorder, the criteria A to C of the major depressive disorder criteria you're seeing right here, they are also representing the major depressive episode in bipolar 1 and bipolar 2. And we will talk more about those when it comes to bipolar disorders. So how do we write up the codes for major depressive disorder? It's a bit complicated for this disorder, so I recommend you to open up your DSM-5 and turn to page 162 so that you can follow along with the lecture. Again, we're not using the codes outside of the parentheses because they are ICD-9 codes, which are no longer used in the field. Instead, we're using the F codes, which are ICD-10 codes. So if you are thinking of someone who might have MDD, then you may want to start writing the code. Start with F3. Those are the first two digits of the MDD disorder. Second, you want to consider or evaluate their current episode. You remember in criteria A, they're saying that people need to display 5 or more of the 9 symptoms under criterion A within the same 2 weeks of duration. So that 2 weeks can be considered as an episode. If this person only experienced that one time before, then you can code that as a single episode. If that person has experienced episodes like multiple times, you could consider putting the specifier of recurrent episode. In order for an episode to be considered as recurrent, there must be an interval of at least 2 consecutive months between separate episodes. In other words, if someone says, I've been depressed in the past month, and every time I experienced for like 2 weeks, then you would know the breaks between those quote unquote episode is going to be less than 2 months. A recurrent episode could be a person experienced MDD in the first 2 weeks of January, and then after 2 months, maybe like March, the end of the March, the last 2 weeks of the March, they experienced MDD symptoms again, depressive symptoms again, then that can be considered as recurrent episode. So single episode is F32, recurrent F33. And now let's look at other specifiers, starting from the severity specifier. According to DSM-5, page 188, specifier mild has been used for people who are experiencing symptoms that are still manageable and the distress that's caused by the symptoms are still not that important, not that significant, right? So on the contrary, severe specifier tells us that the person's experiencing lots of symptoms in great severity and to the point where they can't manage them, things are a little bit out of control, and their life has been severely impacted by those symptoms, such as they probably have to quit the job or drop school. And the moderate is just in between. So you would determine the severity level and then you want to code accordingly. The next specifier is psychotic features. Sometimes people with depressive episode, they will also experience delusions and hallucinations, and those can be considered as psychotic features and can be placed this specifier. If you decide to use psychotic features as a specifier, then you need to follow that specifier coding rather than any of the other specifiers. So maybe you think this person has a single episode mild. So you may, at that point, you probably want to code this person as F32.0 because that's the code for mild. But then you notice this person also has psychotic features, so you have to actually change that code to F32.3 instead of point 0. If the person hasn't been experiencing any of the symptoms in the past 2 months, you can also add the specifier of full remission. Otherwise, you use partial remission. And then there's also a specifier of unspecified, which we don't usually use it unless we need more evidence for that. Just FYI, people don't usually use unspecified because of insurance purposes. Usually we want to do a good enough assessment so we can give people an accurate diagnosis, which can also help them to get the reimbursement from the insurance company. And then as you notice, there are other specifiers can be applied to this disorder without changing codes. And you can just add as many as possible as long as they can apply to the current situation of clients. At the bottom, I have presented an example here. So the code is F32.3, major depressive disorder, single episode, severe with mood congruent psychotic features, with melancholic features, with moderate anxious distress. Persistent depressive disorder, PDD, or simply dysthymia. Criterion A require an experience of depressed mood more days than not for at least 2 years. Criterion B made a list of 6 depressive symptoms and requires people to experience at least 2 of these 6 depressive symptoms. As you can see, all these 6 symptoms have been included in our previous slides, so I will not explain more about any of these symptoms. Criterion C required the person has never been without the symptoms in the first 2 criteria for more than 2 months at a time during 2-year period for adults and 1 year for kids. Next one, criteria for major depressive disorder may be continuously present for 2 years. Criterion E is the same with the MDD, is to make sure that there's never a presence of mania or hypomania. Again, if any of those are present, we're going to think about bipolar disorders rather than depressive disorders. And then the next one requires the symptoms are not explained by another mental disorder such as schizoaffective or schizophrenia. And again, you may also want to screen out more other diagnoses that's listed on the DSM. And then the last one, making sure that the symptoms are not due to substance or other medical condition. Last but not least, making sure the symptoms are severe enough to cause clinically significant distress. And what that means is that it has severely impacted someone's life, impacted the way they function in life. So as you can tell, the major difference between persistent depressive disorder and major depressive disorder is the duration, really. In order to be considered as PDD, the person has to constantly experience the depressive symptoms for 2 years, consecutive 2 years. So what you end up seeing is that person may be diagnosed with MDD first for a couple years, and eventually the diagnosis has been replaced by a PDD. Or the person has never experienced too many symptoms that are sufficient for them to get an MDD diagnosis, so they end up getting PDD diagnosis. PDD also has a variety of specifiers that are available for you to add on. The severity specifiers mild, moderate, and severe are using the same criteria as you used for MDD. And again, they're listed on DSM-5, page 188. And the full remission means that in the past 2 months, there are no symptoms, no signs or symptoms of depression present. With partial remission, there are two situations. You can use the specifier if this person haven't experienced any depressive symptoms in the past, but not long enough to meet the 2 months criteria, or this person has been experienced some depressive symptoms, but they are not severe enough to meet the MDD diagnosis criteria. And if the person also experienced some anxious distress, as described in DSM-5, page 184, you can use the specifier, and you can even specify the anxious distress as mild, moderate, or moderate severe, or severe. Mixed features involve the symptoms of mania or hypomania, but again, the symptoms are not severe enough to meet either mania or a hypomania episode. You can use with melancholic features if they are experiencing symptoms that are described in DSM-5 185 page. Atypical feature specifier can also be found on the same page 185. You can match, you can just compare the client's symptoms to see if they are also meeting the criteria for this specifier. If the person has delusion or hallucination, and the content of those things are kind of also kind of depressing, you can use with mood congruent psychotic features. Otherwise, you can use with mood incongruent psychotic features. So maybe they are seeing something that's exciting or something just unrelated to their moods at all. That could be mood incongruent. If the person experienced some depressive symptoms during pregnancy or in the 4 weeks following delivery, you could thinking about using with peripartum onset specifier. You could specify if this person has an early onset or late onset, depending on whether or not the onset is before age 21. With pure dysthymic syndrome, meaning that the full criteria for a major depressive disorder have not been met in at least the preceding 2 years. With persistent major depressive episode, meaning the full criteria for MDD have been met throughout the previous 2-year period. With intermittent major depressive episodes with current episode, meaning that the full criteria for MDD are currently met, but there have been periods of at least 8 weeks or 2 months in at least the past 2 years with symptoms below the threshold for a full major depressive disorder. And then the last specifier, meaning the full criteria for a major depressive episode are not currently met, but there has been one or more MDD episodes in at least the past 2 years. As you noticed, there's a significant overlap of specifiers between MDD and PDD. The major difference is that there is only one code for PDD, which is F34.1. Adding a specifier will not change that code. And that is not the case for MDD. So that's just something that you may want to consider when it comes to coding. Next, let's look at DMDD, which is short for Disruptive Mood Dysregulation Disorder. This disorder is featured by severe recurrent temper outbursts. The temper outbursts are inconsistent with developmental level. The temper outbursts at least 3 times per week. The mood between the temper outbursts is persistently irritable or angry. These symptoms have been present for 12 or more months, meaning the individual has not had a period without symptoms lasting 3 or more consecutive months. And the symptoms need to be present in at least 2 of 3 settings, such as at home, at school, or with peers. The age range for DMDD is between 6 and 18, and usually the start of these symptoms are before 10 years old. So basically, if you met a child who has some anger issues, you can consider DMDD. Another diagnosis that are also featured in anger symptoms is called intermittent explosive disorder. They are very similar to each other, but the duration of the symptoms and the feature of persistent disruption in mood between outbursts is only a unique feature for DMDD instead of intermittent explosive disorder. If you're interested in knowing more about this, you can turn to page 160 to read more about the differential diagnosis of these two. As usual, making sure that there has never been a manic or hypomanic episode present, the behaviors are not occurred during MDD episode, or better explained by another mental disorder, aka differential diagnosis criteria, and the situation is not due to substance use or medical or neurological condition. Okay, PMDD, premenstrual dysphoric disorder. Criteria B and C made a list of symptoms that are very similar to the ones we already gone through in the previous slides, except that it also include physical symptoms such as breast swelling, joint muscle pain, bloating, and weight gain. So just make sure that when we're considering PMDD, follow criterion A, at least 5 of these 11 symptoms must be present in the week before the girl has the period. And then as soon as the girl has the period, these symptoms will be relieved very soon. Then we want to make sure that the symptoms are severe enough to cause clinical significant distress to the point where that's impacting the client's daily functioning. And then making sure you differentiate PMDD from other disorders that may share similar symptoms, such as other depressive disorders. Criterion F requires that the symptoms are not just a one-time thing. They should be tracked for at least 2 symptomatic cycles. However, sometimes people don't keep track of those things, right? So if there's no clear records of those symptoms, you can just use the word provisional for the diagnosis. So basically, you put the diagnosis and then you put a parenthesis provisional as a provisional diagnosis. And then, of course, once you get more information, you can change your diagnosis to a confirmed diagnosis. And then the last one, just to make sure the symptoms are not due to the use of a substance or another mental condition or medical condition, sorry. This PMDD is usually overlooked by girls because they probably just thought they're having PMS. But for some people, having a period is so scary. It means that they have to cancel all the plan for that day, or maybe for a week before they even have the period. It can cause so much stress, especially among teenage girls who haven't had that much experience yet. So I know this is not something that has been talked about in my culture at all. So I'm just wondering, how is PMS or PMDD or just menstrual cycles perceived in your culture? Do y'all talk about it? How did you learn about PMS? And how is that perception of PMS or menstrual cycle impact on the client's help seeking motivation? In my clinical practice, I've never had to put PMDD, the diagnosis of PMDD on any of my clients. Usually I use PMDD as a differential diagnosis for MDD or dysthymia. What do you think that's the case? Are there more people having MDD and dysthymia than PMDD? I created this slide for a quick reference for the following specifiers: partial remission, full remission, mild, moderate, and severe. And this slide is another quick reference for the following specifiers that are used in depressive disorders, including with anxious distress, with mixed features, with melancholic features, with atypical features, with psychotic features, with catatonia, with peripartum onset, and with seasonal pattern. Towards the end, I'd like to present a few bullet points for you to consider before you make a depressive disorder diagnosis. Number one, making sure that there's a noticeable change from the person's previous functioning. A lot of times you may need to ask help from their friends or family because the person themselves may be too busy trying to deal with everything and they don't really keep track of their symptoms. So depressive disorder is essentially a mood disorder, right? People need to be able to tell you they're feeling low, they're feeling on edge, they're feeling irritable, but not many people knows how to describe how they're feeling. And when that happens, you probably need to try to ask questions in a strategic way. Maybe you focus on their behaviors to see if they have changed any habits, or making sure to ask about their appetite, their weight, and their sleep. And as always, we want to take culture into consideration. Still remember the CFI, cultural formation interview? I'm sure you can get help from some of those questions to better evaluate the client's depressive symptoms. And we've just gone through substance or addiction. And we even had the conversation and talking about how people really like to self-medicate as a coping strategy with their distressing feelings. So always making sure to ask about their substance use behavior, and so that you can screen out any substance abuse diagnosis before making a depressive disorder diagnosis. When it comes to treatment, a few elements stood out. For example, exercise is usually, don't quote me, but in my clinical practice, the hallmark of the start of client progress. For many of the clients, as soon as they started doing physical exercise, I can see direct relationship to the progress of their treatment. It's important to refer them out for medication if they need, especially if they're having active suicidal ideation. If you also want to use other elements on the slides, just making sure that you tailor each of the elements based on the client's characteristics. Have you ever experienced a period where you just feel like you have depression? How did you recover from depression? At this point, you have reached the end of this lecture. I hope you find some of these information helpful. As always, please don't hesitate to email me if you have any questions, or maybe you just want to have a conversation with me.